Welcome back to the deep dive. Our mission today is, well, it's arguably one of the most critical and complex procedures in regional anesthesiology, epidural anesthesia.
It really is.
This deep dive is tailor-made for you, the advanced learner getting ready for board examinations and, more importantly, preparing for those high-stakes decisions you'll be making in the operating theater.
We're treating this as a structured masterclass.
Yeah.
The goal is to synthesize the dense anatomy, the pharmacology, and the technique into what we like to call clinically critical knowledge.
I like that.
We aren't just memorizing facts here. We are trying to understand the why. Why does the dosage change in pregnancy? Why is the onset time what it is? And why are some complications so unique to this specific anatomical space?
That is exactly the right focus. We have a huge array of sources to pull from, covering every single angle, from Batson's Plexus right through to the ASRA guidelines. We're looking for those nuances that separate just knowing the procedure from having real expert judgment. Okay, let's unpack this crucial component of regional anesthesia, starting right at the very beginning. What exactly is the definition and the mechanism of action?
Right. So for your Viva, the definition has to be crisp and totally accurate. Epidural anesthesia is the injection of a local anesthetic solution into the extradural or peridural space.
Okay.
And this results in a temporary, completely reversible blockade of nerve function. We're talking sympathetic, sensory, and motor. It's that ability to selectively manipulate those components that really makes it such a powerful tool.
When we talk about the mechanism, it feels fundamentally different from a single concentrated injection like a peripheral nerve block or a spinal. How does the local anesthetic actually, find its way to the nerve roots?
It's a two-pronged indirect attack, which is exactly why the onset is slower. First, the local anesthetic has to diffuse across the dura mater, which is quite thick.
Right, it's a barrier.
It's a significant barrier. It has to cross that to reach the subarachnoid space and act directly on the emerging nerve roots and the superficial layers of the spinal cord itself. That barrier effect is the primary reason for the slower onset.
And what's the second part of that mechanism?
The second part is crucial and honestly often forgotten in a quick exam answer. The LA also travels laterally. It moves out of the epidural space through the intervertebral foramina.
The exit points for the nerves.
Exactly. And when it exits there, it essentially bathes the spinal nerves in the perivertebral area. So you're effectively performing multiple simultaneous perivertebral blocks at every single segment of spread.
Ah, I see.
So the combination of these two slower diffusion processes is why your onset time is typically, say, 10 to 20 minutes versus the almost instantaneous onset you get with a spinal block.
And since we're talking about injection, we have to immediately clarify the anatomical distinction because confusing the two spaces leads to, well, a total spinal. Let's compare the epidural space, the ES, and the subarachnoid space, the SAS.
This is absolutely non-negotiable anatomical knowledge. The ES is external. It surrounds the thick dura mater. The SAS is internal, it's deep to the arachnoid, and it sits between the arachnoid and the pia mater.
And the contents are completely different.
Critically different. The SAS contains cerebrospinal fluid, CSF, and all the neural structures, so the spinal cord and the cauda equina. The ES, on the other hand, is what we call a potential space. It's filled with fat, loose areolar tissue, nerve roots, lymphatics, and, most importantly, the epidural venous plexus, or Batson's plexus.
The pressure dynamics are fascinating, too.
They really are. The SA's pressure is, simply put, the CSF pressure. The ES pressure, though, especially in the lumbar region, is often described as negative pressure.
But that's a hypothesis, right?
It is. It's sometimes attributed to a kind of vascular suction from the epidural veins, or maybe tension on the dural sac. Clinically, this idea of negative pressure was the basis for the older hanging drop technique, though loss of resistance is much preferred now.
And the patient's physiological state can drastically change that pressure, particularly in obstetrics.
Oh, absolutely. The CSF pressure in the SAS can shoot up dramatically during pregnancy, especially during painful contractions. It's been documented up to 70 millimeters of mercury. This increased pressure influences the spread of LA in both spaces.
And this difference in pressure and contents, it translates directly to that huge disparity in the required drug dosage. Why is the epidural dose requirement so astronomically higher?
It's because the ES is basically a reservoir. It's filled with fat, which sequesters lipid-soluble local anesthetics. It's got blood vessels, loose tissue, all of which absorb the drug before it can even reach its target.
So it's a much larger space to fill.
It's a vast collapsible space. And you have to remember the numbers. To block one spinal segment via the epidural route, you need approximately 1.5 to 2 milliliters of local anesthetic.
Okay, 1.5 to 2.
Now compare that to the SAS. For a similar block extent, you only need about 0.3 milliliters.
Wow, so that's a factor of 5 or 6 times the dose. And that is precisely why epidural anesthesia carries that inherent risk of local anesthetic systemic toxicity last, a risk that's virtually non-existent in a standard single-shot spinal.
That's the trade-off, exactly. Historically, extradural blockade really started its evolution in the early 20th century. It moved pretty quickly from the labor ward into general surgery.
But it's still king in the labor ward.
It is. While newer techniques exist, continuous epidural analgesia, or CEA, remains the absolute gold standard for labor pain.
And what about for non-obstetric surgery? Is it still as relevant?
Immensely relevant. CEA offers superior flexible analgesia compared to almost any other technique out there. It's critical in high-risk procedures, thoracic surgery, upper abdominal surgery, because of its ability to blunt the surgical stress response.
That's a key exam insight.
It is. CEA minimizes the release of catabolic hormones. It accelerates recovery, and it's an indispensable part of enhanced recovery after surgery, or ERA's protocols.
Good.
By limiting that stress response, we see much better outcomes, especially in patients with pre-existing cardiovascular issues.
Okay, so if the exam question is about the anatomy of the epidural space, you need precision. Let's break down those physical boundaries.
You should think of this space as a long, specialized sheath. The superior boundary is the foramen magnum. That's where the inner dura adheres to the base of the skull.
And that's a hard stop.
A critical anatomical limit. Drugs cannot travel cephalad beyond that point in the epidural space. The inferior boundary is the sacrococcygeal membrane, which covers the sacral hiatus. That's your access point for a caudal block.
Okay, top and bottom, what about front and back?
Anteriorly, the boundary is formed by the vertebral bodies, the tough intervertebral discs, and the posterior longitudinal ligament. And posteriorly, we find the laminae and that dense elastic structure called the ligamentum flavum.
And laterally?
Laterally, the space is defined by the pedicles of the vertebral arches and the intervertebral foramina. These are like anatomical tunnels for the nerve roots and blood vessels.
So the lateral boundaries are also the exit points for the local anesthetic, which ties back to that paravertebral block mechanism we just talked about.
Precisely. If the LA couldn't escape laterally through those foramina, the physiological effect would be, well, much more limited.
Let's talk about what's actually inside this space, the contents.
The contents really define the pharmacology and the risk profile. So, loose areolar tissue and fat are the main fillers. And the amount of fat varies a lot. It's quite semi-liquid in younger children, say up to 6 or 8 years old, and it decreases substantially in the elderly.
Which explains why older patients need a smaller dose.
It's one of the key reasons, yes. They require reduced LA doses. Now let's elaborate on the biggest clinical pearl in this section, Batson's plexus.
Right, the epidural venous plexus.
It's a rich, and this is the key word, valveless network of veins that runs through the space.
Yeah.
The fact that it's valveless means that blood flow is dictated purely by pressure gradients.
And that has huge clinical consequences.
2 major ones. First, if your intra-abdominal pressure increases, think about pregnancy with IVC compression, or a patient in the prone position with their abdomen compressed, venous blood is shunted directly into this plexus.
Okay, so it fills up.
It engorges. And second, this engorgement physically reduces the effective volume of the epidural space. This reduction is a primary mechanism behind that 30% dose reduction you need in pregnancy to get the same block height.
That's a brilliant example of dynamic physiology dictating a clinical decision. If you understand the valveless system, you understand why you have to reduce your dose.
Yes. And it also explains why a bloody tap is more common in these high-pressure states, because the large veins are just occupying more of the potential space.
And structurally, the space isn't uniform, is it? It's not just a simple tube.
Not at all. It's segmental, and it contains these fibrous bands or septa that stretch from the dura to the ligamentum flavum in a really haphazard, unpredictable way.
Which explains the dreaded patchy block.
Exactly that. These septa can create anatomical barriers that impede the bulk flow of the LA. They might shield nerve roots on one side or at specific levels, leading to those frustrating unilateral or patchy epidural blocks that we sometimes encounter.
Okay, let's move to the surface. For needle insertion, we rely on palpation and surface landmarks. Let's review the crucial levels.
Starting high up, the C7 spinous process, the vertebra prominens, is the easiest cervical landmark to find. Now, when you're inserting a needle into thoracic spine, you have to remember the anatomy. The spinous process is slant steeply downwards. They overlap the space below.
So you have to angle the needle more.
Significantly more cephalid. To reach the T6, T7 interspace, for example, your angle needs to be quite sharp.
The lumbar spine is a bit friendlier, though.
Much friendlier. The lumbar spinous processes are nearly horizontal, which really simplifies the insertion path. You only need a slight cephalid angle. The landmark you absolutely must know, it's a classic Viva question, is Tuohy's line.
The line across the iliac crests.
That's the one. The line connecting the highest points of the iliac crests. It reliably crosses either the L4 vertebral body or the L4-LL5 interspace. This makes it the preferred, safer entry point for lumbar blocks because we want to stay well clear of the end of the spinal cord.
And speaking of terminations, let's drill down on those two crucial endpoints we must not forget.
Absolutely critical. Number one, the spinal cord, or the concinnus medullaris, terminates at the lower border of L1 in adults. This is the ultimate danger zone. Inserting a needle above L1 carries a high risk of direct cord trauma.
And in infants.
In infants, the cord extends lower, ending around L3, which is important to remember. Number two, the dural sac termination. This usually extends down to the level of the S2 segment, though it can vary from L5 to S3. This S2 landmark is vital for caudal anesthesia because when you inject at the sacral hiatus, you're dangerously close to that lower limit.
Okay, moving from structure to function, how does the local anesthetic physically stop the pain signal?
The molecular mechanism is highly specific. Local anesthetics are weak bases, so they cross the lipid bilayer of the nerve axon in their unionized form.
Okay.
Once they're inside the axoplasm, they re-equilibrate, and it's the ionized form that reversibly binds to the internal receptor site of the voltage-gated sodium channel.
So it acts like a plug.
It's a perfect analogy. It acts as a plug. This binding prevents sodium influx, which disrupts the generation and propagation of the action potential. No electrical impulse can get through. And while the LA eventually spreads throughout the space, the nerve root is believed to be the primary site of action, especially during that initial onset phase.
This brings us to a classic exam question. Defining and explaining differential blockade. This is the physiological process that lets us achieve things like a walking epidural.
Differential blockade is the concept that smaller, myelinated nerve fibers are more easily blocked and require a lower concentration of LA than the larger, unmyelinated fibers. It's a concentration-dependent phenomenon.
So it's all about concentration.
It is. The concentration of LA naturally decreases the further it spreads from the central injection site, and the clinical result is a predictable gradient of block. This is the definition you need to memorize.
Okay, what's the pattern?
First, you get sympathetic blockade. The autonomic fibers go first. This is achieved earliest and extends the highest, often 2 or more segments more cephalid than the sensory block. We judge this by testing for temperature sensitivity.
Loss of cold sensation.
Exactly. Next is the sensory blockade, pain, and light touch. This is generally several segments higher than the motor block. And finally, you get the motor blockade, which requires the highest concentration of LA and is the last to be achieved.
So if we use a highly dilute concentration, we're exploiting that principle. We're knocking out the small pain fibers and the sympathetic fibers, but we're sparing the large motor fibers, which is the whole goal of low-dose labor analgesia.
That is the art of it, precisely.
Yeah.
Now, for the systemic implications, the sympathetic block is what causes the most profound systemic change: cardiovascular instability.
We established earlier that the resulting hypotension is generally more gradual and of less magnitude than with a spinal block. Why is that?
It's purely about kinetics. In a spinal, the LA is delivered directly into the CSF, so it reaches maximum concentration at the nerve roots almost instantly. This gives you a sudden, maximal sympathetic blockade, say, from T5 to L1, before the body has time to compensate.
And with an epidural.
With an epidural, the LA diffuses slowly across the dura. This slow onset allows the body's compensatory mechanisms, specifically vasoconstriction in the unblocked segments, time to kick in. That dampens the sudden drop in systemic vascular resistance and venous return.
But the risk is still very much there.
Absolutely. Hypotension results from decreased SVR and venous pooling. And if the block travels high enough, up to T1 to T4, it will block the cardiac sympathetic accelerator fibers. That leads to decreased heart rate and stroke volume,
Unopposed vagal tone.
which can contribute to profound bradycardia, requiring immediate management with vasopressors and sometimes atropine.
And what about the impact on respiration?
Unlike general anesthesia, an epidural minimally affects pulmonary function, especially with dilute agents. The concern, however, relates purely to the level of the block. If you get a high neuraxial block, that results in paralysis of the abdominal muscles.
The muscles you use for coughing.
Exactly. The patient loses their ability to cough effectively. This significantly increases the risk of postoperative pulmonary complications, particularly in patients who've had thoracic or upper abdominal surgery where pain is already limiting their breathing.
And back to obstetrics, the uteroplacental circulation. Maintaining maternal blood pressure is just paramount for fetal safety.
Uterine blood flow is not autoregulated. It relies directly on maternal perfusion pressure. So if that sympathetic blockade causes severe or prolonged maternal hypotension, it directly decreases uterine perfusion, which can manifest as fetal distress, classically fetal bradycardia.
And what's the high-yield pharmacological management for this specific hypotension?
For the exam, you must state that phenylephrine is the preferred vasopressor for treating maternal hypotension in cesarean delivery,
Why not ephedrine?
because ephedrine causes an indirect release of catecholamines, which leads to greater metabolic acidosis in the fetus compared to the direct alpha agonist, phenylephrine. The goal is always to maintain pressure while minimizing acidosis.
Okay, let's open up the pharmacological toolbox. Our choice of local anesthetic dictates the entire block profile, its speed, its density, and its duration.
And the differences fundamentally rely on two key properties: pKa, which determines the onset, and lipid solubility or protein binding, which determines the duration, potency, and toxicity.
Let's start with the workhorse, the intermediate-acting, fast-onset lidocaine.
Right. Lidocaine has a pK of 7.9, which is closer to physiological pH. This means a larger fraction of it, about 25%, is unionized. This unionized fraction rapidly penetrates the nerve sheath, giving it a fast onset.
And the max dose.
You need to know this: 3 milligrams per kilogram plain, or up to 7 milligrams per kilogram with adrenaline. Toxicity is defined at plasma levels greater than 5 micrograms per mil.
Now, bupivacaine, the long-acting agent with a slower onset but far greater potency.
Bupivacaine is the most potent and longest acting, mainly due to its extremely high lipid solubility, about 1,000 times that of lidocaine, and its high protein binding of 95%.
But it has a dark side.
It does. These properties make it linger at the nerve, but its high affinity for myocardial sodium channels makes it dangerously cardiotoxic. This is the caveat you have to address. Its toxic plasma level is very low, just over 1.5 micrograms per mil, and the max dose is restricted to 2 milligrams per kilogram.
And ropivacaine is the modern solution to bupivacaine's cardiac risk.
Exactly. Ropivacaine is the S enantiomer. Structurally similar, but designed to be safer. It's at least 25% less toxic than racemic bupivacaine, which makes it much preferred for high-volume, continuous infusions.
It has another unique property too, doesn't it?
It does. It has an intrinsic vasoconstrictive property. This naturally limits its own systemic absorption, which further contributes to its safety profile.
So to summarize that for a quick revision, onset is dictated by ppco and the unionized fraction, while duration is dictated by lipid solubility and protein binding.
Perfect. Now, this next distinction is arguably the most important clinical application concept for epidurals. It allows us to completely customize the block.
Concentration versus volume. Let's define them clearly.
Okay, volume is what dictates the spread, the height of the block. A larger volume, say 20 mils, spreads more extensively and covers more segments.
And concentration.
Concentration is what dictates the density, so the quality of the block and the degree of motor block. A high concentration will recruit more nerve fibers and achieve a much deeper, more profound block.
Can you give us the application examples?
Sure. For surgical anesthesia, we need high density and high spread. So we use a high concentration, like 2% lidocaine or 0.5% bupivacaine, combined with a sufficient volume, maybe 20 to 30 mils. This gives you dense sensory and motor blockade, a Bromwich 3.
And for analgesia in labor?
There, we want to prioritize sensory block with minimal motor impairment. So we use a very low concentration, 0.0625 to 0.125% bupivacaine or ropivacaine, to exploit that differential blockade we talked about. This is often delivered via a continuous infusion or PCEA.
Just a quick note on baricity. Since the LA is outside the CSF, it's not really relevant here, is it?
That's correct. Baricity is the density relative to CSF, and it's a factor only in spinal anesthesia. In the epidural space, it's all about bulk flow, pressure, fat binding, and diffusion that govern the spread, not baricity.
Let's talk about adjuvants. These are used synergistically to enhance the block quality.
Exactly, and to reduce the overall required dose of local anesthetic, which improves safety. Opioids are the mainstay.
And fentanyl and morphine offer very different profiles.
They do, and they're classified by their lipid solubility. So you have lipophilic ones like fentanyl and sufentanil. Their high lipid solubility means they partition into the epidural fat. They're also rapidly absorbed into the systemic circulation.
So their effect might be systemic, not local.
It's a key point. Their rapid onset of 10 to 15 minutes suggests that their main analgesic mechanism might actually be systemic absorption and action on the CNS, not just local action on the spinal cord.
And the hydrophilic morphine.
Low lipid solubility, so it lingers in the CSF for much longer, allowing for that cephalid spread which gives you prolonged pain relief. But the danger is its slow clearance. This necessitates stringent monitoring for up to 24 hours because of the risk of delayed respiratory depression as the drug spreads upwards to the brainstem.
Epinephrine, the classic vasoconstrictor, serves a dual role here.
It does. Its primary role is to reduce the vascular absorption of the LA. This delays the peak systemic blood concentration and prolongs the duration of action. It's especially effective with lidocaine. Secondarily, it provides some mild analgesia by acting on alpha-2 receptors in the dorsal horn.
And finally, the powerful alpha-2 agonists, clonidine and dexmedetomidine.
These act by reducing the release of pain neurotransmitters and causing hyperpolarization in the dorsal horn of the spinal cord. Their benefit is significant. They prolong the duration of the block and enhance analgesia. Clonidine, for example, can reduce subsequent morphine consumption by up to 40%.
But the clinical caution regarding this class is critical, especially in obstetrics.
Absolutely. While they're effective, they carry a dose-dependent risk of hypotension, bradycardia, and sedation. The FDA has a black box warning stating that epidural clonidine is not recommended for obstetrical or perioperative pain due to the risk of unacceptable hemodynamic instability in those patients.
So a very clear safety standard.
You have to adhere to it strictly.
All right, technical success starts with the correct equipment. Let's focus on the design of the Tuohy needle.
The Tuohy needle is the standard. Its defining characteristic is its curved, blunt bevel, which is typically angled at about 30 degrees. This curve is a specific safety feature.
How so?
It's designed to gently deflect and push the duramater aside rather than perforating it. This is essential for minimizing the risk of accidental dural puncture and for facilitating safe catheter threading.
During insertion, the clinician is really relying on their feel. What's the expected range of depth?
The distance from the skin to the lumbar epidural space is highly variable. It's influenced by the patient's body habitus. While it typically ranges from 3 to 5 centimeters, the extremes can be anywhere from 2 to 7 centimeters.
So you can't just guess.
You can't. This variability confirms why the loss of resistance technique, which relies on tactile feedback, is so superior to just estimating the depth.
Okay, let's talk about the catheters themselves.
Catheters come in various forms. You have uniport with a single exit hole or multiport with multiple staggered holes. Multiport catheters are generally preferred because they offer a wider, more uniform distribution of the local anesthetic.
And the placement depth is a critical safety point. What is the rule for the length of catheter left inside the space?
After you've located the space and the Tuohy needle is in place, the catheter is gently advanced, usually to the 15 to 18 centimeter mark on the needle. Then, once a needle is removed, the catheter must be carefully retracted so that 4 to 6 centimeters remains inside the epidural space.
Why is that range, 4 to 6 centimeters, so clinically important?
It defines the clinical sweet spot and really the danger zones. If you have less than 4 centimeters in, the risk of the catheter migrating or just dislodging increases significantly. That leads to a failed or inadequate block.
And if you put too much in?
If you insert more than 6 centimeters, the risk of the catheter coiling, kinking, or migrating too far, maybe into the subdural space or excessively cephalate increases. That leads to malposition, patchy blocks, or other complications.
The syringe is integral to the loss of resistance technique. And there's another required piece of equipment, the epidural filter.
Yes, the filter is a key safety measure. It's attached to the catheter hub for continuous infusions. It's designed to trap any particulate matter or bacteria, which reduces the risk of introducing infection or foreign material into the epidural space. It's a crucial layer of defense against forming an epidural abscess.
Let's focus intensely now on the core technique used globally, loss of resistance.
The principle is beautifully simple. It's about detecting a sudden change in tissue resistance. The clinician advances the needle through the ligaments while maintaining constant pressure on the plunger of the lower syringe.
And then you feel the give.
Exactly. When the needle traverses the dense fibrous ligamentum flavum and enters that soft, fatty potential space of the epidural cavity, the resistance holding the plunger back just vanishes.
What are the nuances between using air versus saline for loss of resistance?
Lore with saline is often preferred clinically. The main reason is that it avoids introducing air pockets into the epidural space. These air pockets can physically impede the spread of the local anesthetic, potentially causing patchy or incomplete blocks.
But some people still prefer air.
Some do. Lower with air is sometimes favored because the compression of air feels more distinct. You get a very sharp feel when the resistance is lost. But the biggest risk of using air is the potential for a false allure.
Where does that happen?
False allure is a significant complication trap. It can occur if the needle tip isn't fully stabilized in the dense ligamentum flavum, so you mistake ligament laxity for the epidural space. Or, more dangerously, it happens if the needle misses the midline and penetrates too far laterally into the highly compliant paravertebral muscle. You end up injecting completely outside the neuraxis.
We should pause to consider the structure that provides this tactile resistance. The ligamentum flavum.
Yes, it's classically drawn as a single homogeneous ligament, but that's anatomically misleading. It's actually a paired structure, a right and a left ligamentum flavum that join in the midline.
And their junction is the source of the variability.
The degree of midline fusion is highly variable between patients and between vertebral levels. Sometimes there's a gap, a small ventral opening. This anatomical inconsistency is precisely why we sometimes encounter a failed LOR or, conversely, a sudden and unexpected dural puncture. It's a dense, tough structure, about 2 to 5 millimeters thick, providing that crucial feel.
What about the third technique, the hanging drop?
The hanging drop technique relies on that theoretical negative pressure. You place a drop of fluid in the needle hub and wait for the negative pressure in the epidural space to suck it in. While it's historically important, it's quite subjective and unreliable, especially since that negative pressure hypothesis is debated. LOR remains the superior objective standard.
Okay, the technique itself must be rigorous. Let's establish the boundaries of when we perform the block and when we absolutely do not.
The indications are broad. Surgical anesthesia, especially for the lower body, lower abdomen, or GU surgery, superior postoperative pain relief, and of course, labor analgesia. It's also used for co-induction of general anesthesia in high-risk patients, like those with severe COPD or cardiac disease, to suppress that sympathetic surge of intubation.
And the absolute contraindications are the big red flags.
Absolute contraindications mean you stop the procedure immediately. Coagulopathy, severe uncorrected hemodynamic instability like hemorrhagic shock, and of course, patient refusal.
And relative contraindications.
Those require a nuanced risk assessment. In obstetrics, these might include conditions like abruptio placentae or a platelet count below 100,000, which heightens the risk of an epidural hematoma.
Safety begins long before the needle is even uncapped.
It does. Preoperative assessment involves detailed informed consent, making sure the patient understands all the risks, benefits, and alternatives. We must establish reliable intravenous access and have all resuscitation equipment monitors, vasopressors, volume, intubation gear immediately available.
Positioning is key for both access and stability.
The lateral position is often preferred, especially in obstetrics, because it helps prevent orthostatic hypotension and allows for continuous monitoring. If a pregnant patient requires the supine position for a C-section, left uterine displacement is mandatory to avoid aortocaval compression, which can severely compromise venous return and placental perfusion. And of course, asepsis must be meticulous.
Once access is achieved, the test dose is the most important single safety step. What is its fundamental purpose?
The test dose is the final verification. It's designed to detect an inadvertent intravascular injection or an intrathecal spinal placement before you commit a full, potentially toxic dose of local anesthetic.
Let's analyze the typical composition.
It's generally 3 to 5 milliliters of a local anesthetic, something like 1.5% lidocaine, combined with epinephrine, usually at a concentration of 1 to 200,000 or 1 to 300,000.
And the interpretation, what does a positive test dose look like for each of those scenarios?
For an intravascular injection, you're looking for signs of the epinephrine being absorbed rapidly. This is signaled by a rapid increase in heart rate tachycardia of 20 beats per minute or more, or a transient rise in systolic blood pressure within 60 seconds. A positive epinephrine response tells you the catheter is in a vein, most likely Batson's plexus.
And an intrathecal injection.
For an intrathecal or spinal injection, that small dose of LA acts almost instantly. You'll see a rapid, profound onset of sensory or motor block, often within 3 to 5 minutes. It's far too fast and far too dense for a true epidural block.
We have to reiterate the critical caution about using that epinephrine component in high-risk cardiac patients.
This is a major clinical safety point. The epinephrine component must be avoided in patients with moderate to severe aortic or mitral stenosis. The sudden increase in heart rate and contractility in these stenotic lesions can dangerously reduce filling time, decrease cardiac output, and precipitate acute heart failure or ischemia.
Even after a negative test dose, the risk is not zero.
Not at all. Since we're administering 20 to 30 mL of potent LA, incremental dosing or fractional dosing is mandatory. We inject in small, monitored increments, say 5 mL at a time, waiting a couple of minutes between injections, rather than one single large bolus. This is the single best way to limit the severity of LSD or a delayed total spinal block.
The level of injection fundamentally dictates the field of use and the physiological consequences. Let's run through the anatomical levels.
Okay. Lumbar epidural at L2 to L5 is the standard. It's used for lower extremity surgery, lower abdominal procedures, and labor analgesia. Next, the thoracic epidural from T2 to T8. This is the high-stakes block. It's indicated for upper abdominal and thoracic surgery.
And what are the specific benefits of a thoracic epidural?
The benefits are superior analgesia, excellent blunting of the surgical stress response, and crucially, by blocking the T1 to T5 cardiac sympathetic fibers, it can actually improve myocardial oxygen supply and function in cardiac patients. It also avoids motor block of the lower extremities, which allows for faster mobilization.
And what about cervical and caudal?
A cervical epidural is less common in continuous form due to the proximity to the cervical cord, but it's used for certain chronic pain conditions. The caudal epidural is essentially a low lumbar epidural, accessed via the sacral hiatus. It's very frequently used in pediatric anesthesia for post-op analgesia for lower limb and perineal surgeries.
Continuous epidural anesthesia using the catheter is the hallmark of flexibility. Let's focus on its biggest use, labor epidural analgesia.
Labor pain is divided. The first stage, uterine contractions and cervical dilation, is visceral pain conducted via the T10 to L1 dermatomes. The second stage, perineal pressure and stretching, is somatic pain conducted via the S2 to S4 dermatomes. An effective leader block has to cover both of those ranges.
And what are the preferred drug regimens?
The LU combinations are essential. Low concentrations of LA, like 0.0625% Bupivacaine, combined with a lipophilic opioid like fentanyl. The combination leverages differential block to provide sensory relief with minimal motor impairment. And while epidurals may prolong the second stage of labor, high-quality data confirms they do not increase the risk for cesarean delivery.
This leads directly to the concept of the walking epidural.
The walking epidural is the result of applying that concentration versus volume principle perfectly. It uses very low LA concentration with opioid adjuvants to achieve a dense sensory block while preserving most motor function, a Bromage 0 or 1. This lets the patient ambulate or adjust their position, promoting better engagement in the labor process.
Then there's patient-controlled epidural analgesia, or PCEA.
PCEA is the advanced maintenance technique. It allows the patient to self-administer small boluses on demand, often layered over a low continuous background infusion.
Why is PCEA often superior to just a simple continuous infusion?
PCEA provides superior analgesia and higher patient satisfaction because it allows the patient to tailor the block to their individual needs. And compared to a simple continuous infusion, the boluses prevent the sensory block from regressing, ensuring consistent pain relief while still using lower total doses of the drugs.
And finally, the combined spinal epidural, or CSE.
CSE is the gold standard technique in many obstetrical centers. It combines the immediate, dense onset of a spinal with the flexibility of an epidural.
The technique is defined by a needle through needle.
Correct. We first locate the epidural space with the Tuohy needle. Then a much longer, finer spinal needle is inserted through the Tuohy needle hub to puncture the dura and deliver the spinal dose. The advantage is immediate, profound pain relief from the spinal dose, followed by the safety net of the catheter for extension or long-term management.
What are the specific risks of using this combined technique?
The risk of a post-dural puncture headache is slightly elevated compared to a single-shot spinal. But the greatest risk is the potential for a catastrophic total spinal block if the clinician forgets the catheter is now effectively intrathecal and injects a full, large epidural dose through that dural puncture site.
Examiners frequently test the factors that control the height of the block. The spread is influenced by both controllable and patient-specific variables.
The volume of the LA solution is the single most important controllable factor. A greater volume translates directly into greater longitudinal spread and a higher block.
Does concentration affect the spread?
Concentration is technically secondary to volume for spread, but it does influence density. If the concentration is too low, the effective spread might be reduced because the LA doesn't achieve the minimum blocking concentration at the distant nerve roots before it's absorbed.
The site of injection matters anatomically, too.
Yes. Lumbar injections tend to spread predominantly cephalad, or upward. A low thoracic injection will also typically spread mostly cephalad. The fluid dynamics ensure the LA tends to follow the path of least resistance.
Age is a crucial demographic factor that requires dose adjustment.
Elderly patients need reduced doses because they exhibit enhanced LA spread and sensitivity. This is anatomical. They have reduced epidural fat, which means less depot binding, and reduced LA leakage through the intervertebral foramina. This forces the LA to spread longitudinally, enhancing the blockade.
Let's dedicate some time to the high-yield physiological factor. Pregnancy. Why that 30% dose reduction?
The mechanism is multifactorial, but it centers on the increased intra-abdominal pressure from the gravid uterus causing IVC compression. This pressure forces venous blood into the valvulus Batson's plexus. The resulting engorgement physically occupies the epidural space, reducing the effective volume available for the LA.
So less volume is needed to achieve the same spread.
Exactly. And additionally, the increased CSF pressure further enhances the cranial spread of the local anesthetic.
And finally, the role of the contents of the epidural space itself.
The epidural fat acts as a major depot, particularly for highly lipid-soluble LAs like Bupivacaine. This fat binding slows down diffusion to the nerve roots and slows systemic absorption. The venous plexus, when engorged, reduces the space and enhances spread, but if it's punctured, it causes rapid systemic absorption, which increases the risk of AST.
Okay, complications are where expert judgment really shines. We have to be systematic, identifying the cause, outlining prevention, and detailing management.
The most common is hypotension. The cause is sympathetic block from T5 to L1, leading to vasodilation and venous pooling. Prevention involves preloading with crystalloids, cautiously in cardiac patients, and meticulous positioning. Management is with the vasopressors. Phenylphrine is preferred in obstetrics and rapid volume expansion.
What about the most feared complication?
The life-threatening high or total spinal anesthesia. The cause is an accidental intrathecal injection of a full epidural dose, which is a massive overdose. Management has to be immediate. Secure the airway, intubate and ventilate, and use aggressive vasopressors and volume expansion. You have to anticipate potential cardiac arrest due to the complete sympathetic denervation.
Accidental dural puncture, or ADP, is confirmed by visualizing CSF flow through the needle hub.
Prevention relies on a good loss of resistance technique and the Tuohy needle design. If ADP occurs, the subsequent post-dural puncture headache, or PDPH, results from continued CSF leakage. The hallmark is a severe headache that's positional worse when upright, relieved when supine.
And the management.
Initial conservative therapy is often tried, like hydration and caffeine. But if it's severe or persistent, the definitive treatment is the epidural blood patch, where autologous blood is injected into the epidural space to seal the leak with a fibrin clot.
Local anesthetic systemic toxicity, or AST. This is the signature risk of the epidural technique because of the large doses used.
AST is caused by rapid vascular absorption or direct accidental intravascular injection. Prevention is mandatory. Use of the test dose, adhering to the maximum safe doses, and strict incremental dosing.
What are the signs and how do we manage it?
You have to recognize the progression. It starts with early CNS symptoms, perioral numbness, tinnitus, lightheadedness. This can progress to seizures. And then you get the late cardiovascular symptoms, hypotension, bradycardia, and eventual cardiovascular collapse, which is particularly dangerous with the Bupivacaine.
And the management.
Immediate airway management, benzodiazepines for seizures, and the non-negotiable step. Intravenous lipid emulsion therapy, or ILA. 20% ILE acts as a lipid sink, sequestering the LA molecules and rapidly mitigating their systemic and myocardial effects.
What about neurological and catheter complications?
An epidural hematoma or abscess is rare but devastating, potentially leading to paraplegia. The risk factors for hematoma are coagulopathy or anticoagulants, which is why the ASRA guidelines are so critical. For an abscess, it's poor asepsis or an immunocompromised state.
And catheter problems.
Catheter-related problems are quite frequent. Dislodgement, if there's less than 4 centimeters in the space, or malposition, like a subdural placement causing a patchy block, or the catheter entering a vein.
Inadequate analgesia is a common reality in practice. What are the core causes of a failed epidural?
The causes are usually technical or anatomical. Number one is technical placement issues. The catheter tip is too shallow, too deep, or it's intravascular. Number two is anatomical barriers, those fibrous bands or septa we discuss, which can lead to a unilateral or patchy block. And number 3 is simply insufficient drug, either not enough volume or concentration.
How do we objectively assess the inadequacy of the block, especially the motor component?
Sensory level is checked with pinprick testing. Motor block is objectively assessed using the Bromage scale. This is the only acceptable way to communicate block quality to your team.
Let's run through it.
You must know the Bromage scale criteria precisely. Grade 0 is none free movement of legs and feet. This is your goal for a walking epidural. Grade 1 is partial inability to raise the extended leg, but can still flex knees and feet. Grade 2 is also partial inability to raise the leg or flex the knees, though ankle and foot movement remains. And grade 3 is a complete inability to move the leg, knee, or ankle.
If we identify a failure, what are the troubleshooting steps?
First, never inject a full dose blindly. Check for catheter migration. You can attempt incremental dosing with a slightly higher concentration if it's a patchy block. If you suspect subdural placement, pulling the catheter back 1 or 2 centimeters might help. But if multiple steps fail, or if there's any suspicion of toxicity or a high block, the safest decision is to convert to general anesthesia or an alternative regional block.
Comparison tables are an exam favorite because they demand a synthesis of multiple principles. Let's focus on those distinctions. First, epidural versus spinal.
The core comparison: site and dose. Spinal is intrathecal, small volume. Epidural is extradural, large volume. Onset and density: spinal is rapid and profound. Epidural is slow and less dense, but customizable.
Systemic risk and cardiovascular effects.
Systemic risk: spinal is almost devoid of systemic effects. Epidural carries the risk of LAST, CV effects. Spinal causes a more sudden, profound drop in blood pressure and heart rate. The drop with an epidural is more gradual and often less severe. And finally, flexibility. Spinal is usually single shot. An epidural with a catheter offers continuous, flexible duration.
What about epidural versus a combined spinal epidural?
The primary advantage of a CSE is combining immediate relief with ongoing management. An epidural alone has a slow onset. A CSE provides immediate, dense analgesia from the spinal component, plus the flexibility of the epidural catheter for post-op pain or extending the block. It mitigates the key drawback of the epidural without sacrificing its advantages.
An epidural versus general anesthesia.
This is foundational. An epidural maintains consciousness and has low physiological trespass. GA requires loss of consciousness and has high physiological trespass. For medically compromised or elderly patients, an epidural is often the safer technique. However, for prolonged or truly major complex surgery, GA remains the preferred standard.
A true expert knows how to modify the standard technique based on patient physiology and comorbidities. Let's run through some special situations.
First, obstetrics. We've established the 30% dose reduction due to the engorged Batson's plexus. We also have to remember that all laboring patients are treated as having a full stomach, so aspiration prophylaxis is necessary.
In the
Elderly patients are exquisitely sensitive to LA spread due to decreased epidural fat, so they need a significant dose reduction. They're also at a greater risk of severe hypotension. Fluid management is a tightrope walk. Aggressive preloading can precipitate congestive cardiac failure. Caution and slow titration are mandatory.
What about cardiac disease, like mitral or aortic stenosis?
With valvular disease, you have specific hemodynamic goals. In mild to moderate mitral stenosis, an epidural can be used if we carefully maintain sinus rhythm and control the heart rate. But the key danger is the test dose. Never use the epinephrine component in patients with moderate to severe aortic or mitral stenosis. Tachycardia from adrenaline will dangerously reduce ventricular filling time and can cause cardiac collapse.
And conversely, a thoracic epidural can be therapeutic in cardiac patients.
It can. By blocking the T1 to T5 cardiac sympathetic fibers, it can reduce heart rate, lower afterload, and improve myocardial oxygen supply, reducing ischemia. This is a targeted therapeutic use of the block.
Finally, anticoagulated patients.
The risk of an epidural hematoma dictates a strict protocol. Neuraxial blocks are absolutely contraindicated in patients with any known coagulopathy or a platelet count below 100,000. We rely entirely on the American Society of Regional Anesthesia, or ASRA, guidelines. Adherence to ASRA is the legal and clinical standard of care in this high-risk population.
We've covered the entire spectrum. Let's distill this into a final high-impact review, focusing on what the examiner wants to hear.
You should be prepared to write comprehensive, structured answers for long questions on the anatomy and applied physiology of epidural anesthesia, factors affecting spread, and a full section on complications. For short notes, expected meta 1, combined spinal epidural, postoperative epidural analgesia, and the detailed anatomy of the space.
Give us those quick-fire facts we have to have ready.
Okay. Epidural capacity per segment, 1.5 to 2 mils. Termination of the dural sac, S2, S3. Termination of the cord in an adult, lower border of L1. Sympathetic block level for hypotension. T5 to L1. Test dose composition, LA plus epinephrine. Catheter length in the space, 4 to 6 centimeters. Max Bupivacaine dose, 2 milligrams per kilogram. And Bromage scale grade 3. Complete motor block.
Let's quickly review the pharmacology one last time, connecting potency to safety.
Mentally review this triad. Bupivacaine is the longest duration, highest potency, and highest cardiotoxicity. Lidocaine is the fastest onset, intermediate duration, and least cardiotoxic. And ropivacaine provides the duration of bupivacaine with a significantly lower risk of cardiotoxicity, making it ideal for continuous infusions. If we connect this to the bigger picture, mastering the epidural technique is the ultimate integration of applied anatomy, dynamic physiology, and detailed pharmacology. It's about moving from just a procedural skill to real clinical judgment. It's about knowing precisely why a small change in volume dictates the outcome, why the pressure in the space determines the dose reduction in a pregnant patient, or why you must categorically avoid adrenaline in the setting of severe cardiac stenosis. Safety is in the titration and the judgment.
We have dissected the evidence, traced the path of the local anesthetic, and compiled every high-stakes clinical and exam detail needed for mastery. This is a comprehensive review you can come back to again and again as you refine your technique. We noted that while epidurals offer superior analgesia and blunt the surgical stress response, recent fast-track surgery protocols for minimally invasive procedures sometimes show that high epidural blocks might actually prolong in-hospital recovery. Here's where it gets really interesting. Why might minimizing the sympathetic block, which is what we achieve with a low lumbar epidural, be detrimental or unnecessary in the era of fast-track low-impact surgery? Think about the role of the sympathetic system in maintaining mobility and preventing deep venous thrombosis. This is a question worth exploring for your future practice. Now go deep,